Okay. All right, Sharon, I'm just going to introduce you here. Hello, everyone. Thank you for joining us for our virtual seminar hosted by the Frontier Nursing University chapter of the Institute for Healthcare Improvement Open School of Healthcare Professions. We are excited to welcome Sharon Rising, a certified nurse midwife and founder of the Centering model of group healthcare. Her innovation and leadership with this model of care has spread to over 400 centering sites in the United States. Sharon has proven leadership in both clinical and healthcare education. In addition to her work on improved model for prenatal care, she established the nurse midwifery program and the child rearing center at the University of Minnesota. Her distinguished honors include the 2006 Yale University School of Nursing Distinguished Alumni Award, Civic Ventures Purpose Prize in 2008, the American Academy of Nursing 2010 Edge Runner Award, and the 2010 American College of Nurse Midwives' highest honor, the Hattie Hirschmeyer Award. Sharon joins us today to talk about the Centering Pregnancy and Centering Parenting model for group prenatal care. We will share quality outcomes of the model and discuss how the model fits with the Institute for Healthcare Improvement rules to accelerate healthcare redesign. Finally, she will share strategies for overcoming barriers and accelerating change in the practice environment. Please note that we will be monitoring the chat box, so if you have questions or comments, we will address these at the close of the presentation. Sharon, thank you for being with us today. And your presentation is up. I've given you moderator privileges, so you can take it from there.
Thanks, Judy. It's great to be with you and with all of the attendees. It's always a pleasure to be able to talk about centering, the group model, and to share my enthusiasm for how it is changing outcomes and changing care, especially for the women and babies that we care for. I'm going to run through very quickly because I understand that some of you are pretty familiar with the model and some of you maybe not so much. So I'm going to do an overview, a brief overview of the model and some of the research, and then, as Judy said, talk a little bit about kind of what are the challenges and where do we go from here. So to start, I think this is really relationship-centered care. Someone asked me the other day, in fact, one of the new physicians who just joined their board said, so where does family-centered care fit into all this? And I said, well, it is, but part of it certainly, but this is really relationship-centered care. With our mission being to improve health by transforming care through centering groups. So there are many relationships that we have as we provide care. There's a provider to provider one or clinician to clinician. There's the relationship to the family and to the community and all, but the really strong relationship in centering, I think, is the woman-to-woman relationship that happens and builds within the groups. You know all about the triple aim, and we think that centering meets the goals of the triple aim. With better care, we have 97% patient satisfaction, better health, especially compelling with the lower risk of preterm birth, and lower costs with the savings that we are seeing, primarily from the reduced use of the NICU. But there are certainly other components that lead to savings. So if you're thinking about that, you might be thinking, oh, those hospital administrators might be a little nervous about having to close some of their NICU beds, which I understand has happened in some places. Big in financial concern for hospitals. I don't know why groups. I'm guessing that all of you have had some experience in groups. I mean, groups are just fun. And for me, when I developed this, I was really tired of saying things over and over again all day. And so to be able to talk with women within a group setting was so refreshing to me. And from a woman's standpoint, they might say something like, it's what you imagine when you're having a baby. It's personal, loving, relaxing, and an amazing community. And we do think that the community building, may be the most important piece that comes out of centering, of receiving care through centering. If you are looking for research projects, there are tons of them and a lot of research questions that can be, that we'd like answered. So this is care, and just as a quick visual here, everything is put together. It's all bundled and happens within the group space. So women aren't making a lot of independent excuse me, appointments that they may have some trouble making, everybody comes or everything comes to them ideally within the group space. So you can see how dynamic this is and how comprehensive it is in terms of providing really a holistic care for moms. So there are three components, which in my mind are the really important things to remember about this. One is the health assessment or the health care itself happens within the group. So in case I forget to say it later, this is billable because it's care. It was one thing that I was quite concerned about when I developed the model. I didn't want a model that was dependent on grant funding, and because they just go away when the grant funds go away. So this is reimbursed in the system, and we're now having some success with enhanced reimbursement. There's also interactive learning. We used to call this education, and education really signifies to me perhaps a passive relationship with somebody in charge who is presenting and others are listening. We have some good education models, but a lot that aren't. And this is interactive learning because it was clear to me I was learning as much or perhaps even more than the women in the group. It's very dynamic. Leading groups has been a very dynamic experience for me. And the third one is community building, which we used to call support. And support has a softer, a more nebulous term perhaps, but we really feel that we're building community one group at a time. And another area for research would be from a sociological standpoint, perhaps, is to look a little bit more about what is happening within the zip codes that are contributing the most women to the groups. Those of you who have had some long tenure with centering know that we had 13 essential elements. We've now reduced them to 9. We've just combined some of them. And honestly, I am now calling these defining elements rather than essential elements. And we're going to look just briefly at each one of them. But they're what make the model work, the 3 components. They help to define that. So if we were going to look at, so the first one, so the health assessment happens in the group space. So there's no need for an exam room unless there's something really terribly private, and that would need to be followed up on at the end of the group. But most all of the assessment happens within the group space itself. The assessment area should be knee level or below. I did all of my groups with a mat on the floor, and that worked well for me and for my moms. A lot of people use perhaps a massage table or something that's slightly higher. And so you see here that the dad is involved, of course, and the midwife is listening to the baby. Another one of the defining elements is that the women in the group, patients, are engaged in self-care activities. So they take their own blood pressure, they do their own recording, they keep up chart notes, they have their own progress notes in their centering notebook to keep track of their progress and to set goals. So they weigh themselves and do their blood pressure in CenteringParenting, which continues the model through the first 2 years of life at least. Parents are also involved in measuring their babies. And I'm thinking that this little baby holding the tape measure is giving his or her daddy a little bit of a run here as he's trying to do the measurements. Groups are facilitated to be interactive. This, we feel, is at the core of the success of the group experience itself. And what this means is that the clinician, we, midwives, physicians, whoever are the facilitators, have to learn to be quiet and to listen and not answer questions. Because once we answer a question, we won't know the wisdom of the group because we'll still be seen as the authority. So the facilitation is the focus of our workshops, to learn how to do that, to have fun, to have games that can be used, different techniques, so that moms are really involved and that you don't feel that you have to talk a lot or have a lecture. An open circle is needed, so we'll talk just a little bit later about how this is one of the challenges, having the appropriate space. But it's important not to have a table in the middle because there are games and other interactive activities. So having an open circle where everybody is in the circle is important. And the size is optimal both for interaction and for productivity. So we think that somewhere between 10 and 12 women would make up the group cohort that stays together through the pregnancy. If you have it much smaller, then the productivity issue may arise, and because the group session itself usually is 2 hours in length. Groups start and end on time. So in a 2-hour period, if you can see 10 women and bill for 10 women, that usually meets productivity standards. It also is a nice size group for interaction because maybe they will bring their partners or another support person, and then you might have 20 in the room, and that's a lot to manage. So you wouldn't want more than that. On the other hand, if it's too small, it may be hard to get the interaction going. This is a parenting group. You can see slightly larger than the other one, but a lot of dads. Each session has a plan, but the emphasis may vary. So this is a process. This is a process model, not a content-driven model. So while there is content and there is a design for that is developed that runs through the 10 sessions of prenatal care or the 6 sessions in the first year of Centering Parenting or the 3 sessions in the second year of Centering Parenting, there's not really a mandate for what has to be discussed. So you talk about what the women are really interested in talking about. There's a self-assessment sheet that helps to spring the content. And of course, you have some thoughts up your sleeve for how to get the discussion going. But sometimes your thoughts are not the women's thoughts. And so the emphasis may vary. And there's consistency. So there's a clinician and a co-facilitator that really, I just call it own the group. So you are with the group through the entire 10 sessions. If you're credentialed to do well baby care, you might simply continue on into Centering Parenting, which is well woman, well baby care, or postpartum care, well baby care for the first year of life and beyond. And the cohort stays the same as well. So there's trust that builds up in the group. In fact, there's a new article that I really like. It's from the Netherlands. It's called The Role of Trust in Centering Pregnancy, Building Interpersonal Trust Relationships in Group-Based Prenatal Care in the Netherlands. It's in a recent issue of Birth. So that having that consistency is important. Remember community building. And so this consistency, it's a real commitment to the group. And there's time for socializing. So again, community building. There needs to be time for women and for the other group members to get to know each other and just to have unstructured time. So that might happen around the food table. Healthy snacks really help the socializing piece of it. We think that's important. So it might happen there. It may happen in the circle before there's been a formal circle up that's happened, or perhaps at the end as women get to know each other, they often go off together hand in hand, or sometimes go out for lunch or dinner. But again, the socializing is an important piece. And then there's ongoing evaluation. So it's really important to know whether care got better. And you're not going to know that unless you collect data. Collecting data is rather tedious. It's time consuming. And, you just hope that you have someone around who really likes to record numbers and keep up the Excel sheets. The CHI, Centering Healthcare Institute, now has centering counts where our member sites are inputting data. So again, really important to know this. A lot of the data that will be collected will be based on the site's benchmarking, what are the things that you would like to see that go better, that and these do vary from site to site, but looking at what is, and then where do you want to go, having the vision where you want to go, super important. We in the early days, so I developed this in 93, 94. First workshop was in 98, and the second workshop was actually attended by Jeanette Ickovics, who's a psychologist at Yale, and was really interested in the model and wanted to do some research, careful research on it. So the first study that was done was a matched cohort and was published in 2003, prior to this particular one, and that had women from public clinics in New Haven and at Grady in Atlanta. Showed that if you were going to deliver preterm and you were in a centering group, you stayed pregnant 2 weeks longer and had a baby a pound heavier than your matched pair. That was the first that we knew that this was having an effect on preterm birth. Now, prior to that, I knew that women loved it, and I knew that I loved it. And those are the two things that were really important to me, that the outcomes were going to be good. I had no doubt about that, but the women really loved it. And I wasn't repeating myself all day. And so it gave me a whole new lease on continuing my clinical midwifery. So it was a really important piece for me. So then the research outcomes randomized control trial, actually this was published, I see the slide is not quite accurate, was published in 2007, which showed, and had over 1,000 women, but showed that if an overall reduction in preterm birth by 33%, and then 80% of the sample was African American. All of the women in Atlanta were Black women, and in that group there was a 41% reduction. And I think we couldn't have been happier, because we all were quite focused on the birth outcome disparities, and felt that if we could affect the outcomes there, that would be great. Another team led by Amy Pickelsheimer, who is now Amy Crockett, in Greenville, South Carolina, also was collecting data. And we'll talk about the South Carolina story in a minute, but they found very similar results in their between their Black and white women. And in fact, they were slightly better even than our randomized trial results. This was a retrospective cohort. So, and then the second large randomized trial happened in 14 community health centers in New York City. This was again done by the same team at Yale. And when we get again to challenges, we'll talk about the problem of enrollment of women and what happens with very dysfunctional clinics. But here we looked at, for women who attended at least half of the visits, that meant they came to at least 5 of the visits. There were over 1,000 women who fit that again, they were less likely to have a baby preterm or low birth weight, and they had greater satisfaction. So again, we were feeling encouraged, and we still look at all the data very carefully to be sure that we still see the same trends. The question of why does this work, or is it really important to do the model as designed? This study looked at the data from the first randomized trial to see what seemed to be connected to the preterm birth outcomes. Was it that women who weren't smoking or who hadn't had preterm births, or some other variety of variables that could be looked at? Was there any relationship? And what was found with this was that the only relationship that held up was that women who were in groups that were rated by the research assistants as having greater facilitation were the ones less likely to have a preterm birth. So it was it's been a confirmation of what we have thought. So how you think things, and it's really nice to get data to help to support your thinking. But that it really is the heart of this is really the facilitation. And then there was a secondary piece that of community building, how really connected the women were. So this was also a very important article. came out a while ago. We also asked women, what did you like best about your prenatal care? And I kind of love this slide. This is again from the first trial, but they, look, here's the provider for the group women, and here's a provider for the individual care women. So provider important here, not so important here, but look at the interpersonal. This was what was really, really important. What did women like best? Was being with other women, and having an opportunity to get lots of information and to share information and to test out their basic assumptions. And the ultrasound really wasn't that important, which was interesting to us and fun sharing, I guess. Also, I looked a little bit at the qualitative data because I happen to really like the qualitative data, probably more than the quantitative. But these are some themes that came out that were similar in studies that came out from physicians and midwives and women. So common themes: not feeling alone, friendship, fun. I mean, imagine thinking that work is just so much fun, and I want to do care this way because it's fun for me. But knowledge is power, and taking ownership, etc. Support, respect. So these are really strong. These are strong qualitative outcomes, and now we might be able to add something about trust to the trust in community building. So kind of a quick summary. We talked about the decrease in preterm birth, increased breastfeeding. So you can kind of read these over, but we don't want women getting pregnant in that first postpartum year, and so that happens, and it happens even more in centering parenting, where we could continue to emphasize that the importance of good kind of family planning plan. I know one of the really early on in one of our early centering parenting groups, the family physician said to me, well, it was really fun in that first session. The women came together and they were talking, and they discovered there were 2 women in the group that didn't have a birth control plan, and they fixed that. I didn't have to say a word. And so as the women get to know each other, they become much more active, I think, in caring for each other. There's better attendance and, again, high satisfaction. So again, just another way to kind of look at the summary: 97% patient satisfaction, the preterm birth rate, breastfeeding rate, and low birth weight. These are the main things that we're looking at and are keeping track of through Centering Counts, which is the program that CHI is using, and that is getting input from all of our approved sites. So just a little bit on the what is happening in Greenville, South Carolina. So this is the Amy Picklesheimer Crockett and Sarah Covington Kolb story. I think Amy was early on when they got started here, started collecting data on centering. She is an OB-GYN and had learned some about centering during her residency. Didn't think too much about it then, but was really concerned that she didn't think the outcomes from their care in Greenville were that good. And so started to collect data and took this data to the state Medicaid director. Some of you know about Strong Start, maybe all of you do, which was a grant call for enhanced prenatal care with primarily with 3 arms: birth centers, group care, centering, and maternity medical home. And in the early days, if you were going to apply, you needed to have a relationship with your state Medicaid director, which I thought was really a brilliant idea. However, that became so problematic they had to drop that as a requirement. But Amy went to the South Carolina Medicaid director with her data and said, this is what we're seeing. And the Medicaid director said, look, we don't really need federal money. I have money and I can be helpful. So between 2009 and 2013, you can see here what they were able to document and and were able to put this into a cost formula to look at the savings. And so you can see here over $3 million in savings that they felt they documented with prevent the decrease in low birth weight, preterm birth, and NICU admission. So the Department of Health there and the Birth Outcomes Initiative, which got started, was a very strong initiative in South Carolina. Some of you may be from there, maybe you've been to one of the meetings. There's a group of people there, multi-professional providers and all, who meet every single month to try to look at preterm birth and improving their outcomes in the state. It's been quite amazing. But the state Medicaid decided, based on what they were seeing for the data, to provide enhanced reimbursement. So you can see what's there. They $40 per patient per centering visit was given to the managed care organization. $30 was passed on to the provider, who, providers in clinics seldom see the results of their labors in terms of additional money. And $200 was the cap on the patient. So you could get up to $200 per patient. So that's a really good incentive. There was a modifier code that was set up, and then the state coordination happened. Sarah Covington-Kolb has been this really state coordinator, and there has been they have invested in up to 19. There's now 19 sites. So the state Department of Health gave money for the startup costs and the sites had to bid for that. But now there are 19 sites in South Carolina. 11 are approved. 3 are in the process, and there are 5 new ones that just started in 2016, and they have over 3,000 deliveries. So it's part of the story of South Carolina. There's a lot to say about it, and that's all I can say tonight. But is that it's collecting data and knowing what's happening in your own state, and are things getting better, and then continuing to build on that and identifying who are the key players in the state, or at least in the institution, but the state, who can make a difference and lead to something that's happened here. So you can see here is a little bit more on the cost savings that they have. So again, over 7 million in net savings so far. So it's a huge amount of savings. I remember quite a while ago talking to the head of the CMMI, Center for Medicare Medicaid Innovation, and that person saying to me, this is the millstone. Pregnancy is a millstone around our neck. We have to figure out how to get better outcomes because it's costing us way too much. Well, there have been some attempts to really change, to really make a change in how South Carolina is kind of population change. So we want population change. How are we going to make this happen? You may remember that in 2001, there was a seminal document that came out from the Institute of Medicine called Crossing the Quality Chasm. And in there were 6 aims listed and 10 rules for redesign of care. We published in 2006 the 10 rules and how we thought centering responded to those. And one of them was really focused on patient-centeredness. And I remember reading in the Crossing the Quality Chasm that the patient-centered care, it said something like all the patient's values and beliefs should guide all our decisions should be based on the patient's culture, beliefs, and values. And I thought about that a lot, and I still do, and think, how could we possibly do that in individual care, given the time constraints that we have and the number of women that we are caring for? So again, it seemed to me that group was a way to really begin to look closely at how well we're doing with that. And then just this year, IHI, which all of you are familiar with, came out with 10 new rules to accelerate healthcare redesign. And so as part of our work on the book that Charlotte Quimby and I have written and is just out, the Centering book, I took those 10 rules and looked at, okay, what does centering have to say about each one of the 10 new rules? Because it's like, this is to accelerate. we need to make things happen rather quickly. And, 2001, but we made some progress, but not a super amount. So out of the 10 rules, and I guess you have them, right? On that sheet of paper. This is where I go, and I just bring this one
Right.
up. Look at that. I remember how to do that. That's great. So you have something that looks like this, I think, or you can access it.
Yes.
So this is what I am referencing now. So I took 4 of those rules, and because they particularly they spoke to me. And this picture, you probably can't figure out what in the world it is, but it is a monkey that actually my grandson took when he was in Rwanda last year, and I loved it because I think it speaks to all 4 of these issues. So sorry that the picture isn't slightly better, but there you go. So the first is changing the balance of power. And one of the things I just want to say about this is that we need to be at the table. We need to be at the right tables, at the boardrooms and the design rooms and the financial planning boards. So we need to be active in being there and not sort of picking up what happened when we weren't there. Promoting well-being, I think, is the well-being of us, our workers, as well as of the moms that we care for. And there's a tremendous amount of change that happens in groups as you watch the group and women help each other with that. Creating joy at work. Well, this is why I started this in the first place, but we should be happy. We should enjoy this. We should feel that we should be able to look at what's happening as a group relates closely to each other and feel real good about the group taking over some of what we might personally have felt was our responsibility. And then the last one, I don't have much time. I see my clock is saying I'm running out of a little bit of time here. So I do want to keep moving along, but I do want to say that I think that maternal child health has been given the crumbs through the years, and that many of us have felt we're just grateful that we're grateful for space. I can remember a CenteringParenting group that I observed, and it was just a horrible room it wasn't clean, and children, these babies were on the floor and all, and the pediatricians looked at me and just said, "Don't say anything. We're just glad we have a space." And some of you may have had that experience yourself, and so we need to assume abundance. The most important people really are our mothers and our babies, and that's the upstream downstream story, which I'm sure you know very well, but it's where we need to be putting the majority of our attention. So how do we move forward? Well, first of all, there has to be readiness for change, and we just say there needs to be a cohort of patients, and space and support and some funding and training, and with the majority of people saying, yeah, I'm going to support this, a majority of clinicians participating, being part of it. So are we ready for change? And this little thing says, well, this is good work, but I think a little more detail is needed right now. It's not just a miracle. There's a lot of work that needs to happen in order to change. And we should be thinking sustainability as we're changing. So here are the system redesign components that I think all need to be attended to. And so the planning process for change is a real big one. You can just quickly see all of these, and all of them intersect with the steering committee that has appropriate representatives from the different areas of the agency that really important to make this work. And there's a coordinator, somebody who oversees this. So it's not something that's done after work hours or whatever, but this is part of the job to make this kind of change. And it's absolutely critical to have patients involved in this. So, and not just one patient, but more than one patient who can give input and really come up with, they will come up with ideas that you haven't thought of. They'll help with messaging and marketing, what have you. So the steering committee guides this whole process, and it makes all the difference to the success. And I think a steering committee works really hard, especially in the first year or two, but then probably just never goes away. Needs to always oversee what's happening. So I just pulled out some common challenges to to making this work. I mean, first of all, there's resistance to change. You know, even though we're not happy, it's hard for us to change. It's hard to take that step, and even if we do take that step, it's really easy to fall back into the rut. So resistance to change is a big one, and putting time in at the beginning to really talk about this. What does it mean? Going through a process of system redesign, looking at every one of these components and making sure that this is something that has ownership. You know, involvement equals investment equals ownership, and so involving people in all of this, very important. Finding appropriate space. This is care. So as I've been in some very well-known places and looked at their space and said, you know, this is patient care, really? Think about it. This is patient care. And so having the appropriate space, it's private and that feels really nice. It should feel like a nest, a place to come to, that the group members really want to be there. They feel safe, because a lot women will share things in group that they haven't shared to anyone, haven't shared with their providers at all. But it has to be a safe, welcoming space. There needs to be some money for startup and for training, and you know, there's supplies, there are materials and food and all, so there is some money involved, but it needs to become a line item in the budget if it's going to be sustained. And then patient enrollment. I mean, Judy Butler was just telling me that they have now gone to a group intake session. There are different ways to do this, but you know, doing something new is kind of scary and may not be something that women want to take a risk on. Actually, it's unusual to lose women who have come. But getting them to that session is hard, and so having really positive messages is a really important piece of it. So I was just this is group space. The space on the right actually what used to be a medical records room. And when the medical records went away, the midwife who was there was on the ball at the table at the right time and said, I want that for my centering groups. And it's great space. She's been able to do a nice job with it. On the left kind of gives you an idea of how an assessment area might look. Again, within the group space, but still very private. So it takes work. I mean, it can happen, but it does take work, and then sustaining it. It's one thing to get it started, and it's another thing to sustain it. So that's kind of what we're looking at, and I just wanted to throw in that I am working now on our Centering International, which we have just is a single member LLC of CHI. And I've done work in Africa and in the English-speaking world, and so we have groups in Nepal and in more than one country in Africa, and Brazil also was there. And you know, there's just a whole lot of interest internationally, and we know that the issues of moms and babies, we have a lot of them in this country, and then when we look at the real challenges in the developing world, we know that perhaps we have something to offer. So, but change is good, and you go first. You know, somebody needs to be there to start it all. So it's as I said, the focus should be on sustainability, and that's part of the. If you're going to look at it from a quality standpoint and what is going to really make a difference, picking out the things that really are going to make a difference, and then looking at not just immediate change, but what do we need to do in order to sustain this change. So that's kind of the end of what I want to say just formally, and then I think there are some questions, and we can open it up to some discussion.
Sure. So I'm just going to start at the top, Sharon, and read these questions. Diana Jollis, my other doctoral program director with me, says, having been a pioneering force in change, innovation, and healthcare redesign, what advice do you have for students who are struggling with barriers to change within the clinical setting, especially resistance from the team?
So it's hard. You really need to have a buddy. And it's kind of, I mean, I just say it usually doesn't work well to go it alone. I mean, when I started this, I really was alone, but I'd had lots and lots and lots of experience, and had come from a very creative model that I'd been able to develop in Minnesota. So sort of had some tools under my belt. But I think it's hard to do it alone. So look for the people who kind of think like you do, and maybe go to lunch. Take people to lunch and talk with them about your idea, and who should I talk with? I mean, in this area. So think about medicine and nursing and administration, and where are some key patients? How do I start putting together really a working group for this? And talk to your mentor about it, and don't try to do too much at once. So I think you have an idea where you're going, a vision of where you're going, but you should be familiar with the literature, and talk with people in other parts of the country, perhaps, who are in a situation that's sort of like yours. If you're in an FQHC, maybe a couple other FQHCs, or maybe it's a standalone clinic, or maybe it's a private practice or a birth center. But look at, how to gather some data. How did you do it? What were the barriers?
Well, you're speaking to the DNP group, so we're with many other people. So you said all the key words that we are trying to instill into their brains. So we thank you for that plug. Her second half of her question is, what is your vision for centering pregnancy and centering pediatrics in 10 years? Will the model be actualized to scale? And what can FNPs, WHMPs, and CNMs do to support the movement to scale?
So first of all, one thing I didn't say, but that I do want to say, is that centering healthcare is a model that fits for really any health population. So we have centering groups that work with people with sickle cell or HIV or other drug-related issues, with pelvic pain, for example, with obesity. So the model itself is really flexible and works with different populations. Centering pregnancy and it's really centering parenting. So it's interesting that you said centering pediatrics, because that is how it's being rolled out in a lot of places. Pediatricians sort of have trouble thinking about woman care. And so we don't have time to really talk about that. The postpartum period has been my personal passion all along. And so it's been, if you think about having women in a cohort for 10 sessions, so that's over a 6-month period, and going through delivery together, coming back after delivery with their babies, because everybody wants to see each other's product and tell their birth story too. There's a real bond that has developed in most groups. There are groups that they don't get the tightness that, so not every group is, groups aren't alike, as you know, but most of them come together very strongly. And so now with centering parenting, this is an opportunity for women to set their own goals as well. So their weight goals, and have depression screening and ongoing contraceptive care, and family violence, looking at family violence, are all, and then continuing with breastfeeding. So those are sort of the major 5 things that I think are there for women in that first postpartum year. And babies, then you look at the baby. So we know mothers, it's a dyad, right? And that they thrive. One thrives if the other is thriving, and vice versa. But it's a very important relationship there, and the attachment is important as well. So all those things then play out within the group, and again, women really support each other. What is my vision? I don't. So I'm kind of biased, but I do think that women like it better than traditional care. The outcomes continue to be better for moms and babies. This is a challenge for the systems. And so when our buildings aren't built with really lovely group spaces, and so as more places are doing this, and as we get more data, there are over 200 articles published on this model, and most of them extremely well done. I would just like we would like this model, of course, our mission to be available to anyone, any mom who would like to get care this way, and then to carry on to provide ongoing care to the dyad, to the mother, and to the baby. Now, some places the mom is sort of a little more incidental. The baby, of course, is the main billing agent for that first year of life. So we do have some well woman codes now, if we can hang on to them going forward. But we do have some codes, and we can, and of course we can bill for the babies. So if you're an FNP, um, uh, that's just a great degree to have, or I think probably maybe the best one for this combined model. So if you're a midwife or a women's health nurse practitioner, you can, you partner. And so you look at who you can partner with and do it in a way so that it still becomes cost effective. So yeah, I'll stop on that one.
All right, Paula Wadowitz is one of our DMP students, and she just finished a project in collaboration with her MD. And she says, how do you see centering pregnancy improving collaboration among disciplines, especially for high-risk women requiring follow-up in addition to CP sessions, to increase patient access to care and improve efficiency?
Well, it's so if you have a group, you can just think about access. I mean, you have a group starting and women come in and who are enrolling at about the same time, and right away they get into a group and get started with their care. I think access is one of the major advantages for the system. It also releases exam rooms for paying procedures. So it, sort of right sizes how and where the care should be delivered. I think that it's a really wonderful collaborative model. In fact, the first article that I published back in '98 was talked about the collaboration. It was really focused on that. We have again, depending on your credentialing and on the scope of practice that's allowed at your site. I mean, Nurse-Midwives and women's health nurse practitioners are doing are able to do different things. Like, for example, one of our sites, the Nurse-Midwives, are managing all of the women with diabetes, all the pregnant women with diabetes, because they have so many, and the physicians are there just for women who really are not doing well with the sort of standard treatment plan. But if a woman develops a high risk problem and it is outside of your scope of practice, you have a relationship with perhaps a maternal fetal medicine physician, or maybe it's a family practice physician, depending on, and then you collaborate. And so a woman might make a few extra visits. What I found on my own site was that the physicians knew me so well that it really cut down on the number of individual visits a woman needed to make to the high risk provider. So I think you do work out. The social worker gets involved, maybe the physical therapist, you have the nutritionist. It then becomes a team caring for the women, and it feels really nice.
Okay, great. My question just went away. Linda Cole had a question here. She said she's been involved in centering as a midwife for many years and loves it. How has centering been adopted within OB residency programs, and how might it be best used for interprofessional education efforts?
Yeah, that's a very important question, and it's one that we've been looking at, and that I'm looking at now, especially with the centering book being out. There are a number of residencies around the country where residents have the opportunity to be involved. There are some residencies, I know there's one in New Jersey, I think, where the residency director there said to me, so every single resident here does a group. that goes through our program has to do a group. And I said, so what if they don't want to do? And she said, that doesn't matter. They have to do it because it changes them. I see what happens to them. And when they get out, I'm hoping that they will continue to provide care in groups. We're involved with CREOG. And so I think, yeah, I mean, we just all, I don't know that even all of our midwifery programs in fact, I know that they don't. We did a little survey on that, that the students have an opportunity to be involved with centering. So I frankly think it's really important that this is a midwifery model of care. It exemplifies that beautifully. And it is a transformative experience for students to be involved with mothers on this level. I remember an OB-GYN resident at Yale who I was talking with. I observed lots of groups at Yale during the trials, and she said to me, she came to me and she said, every OB resident should have to have the opportunity to be with a group of women throughout. And this is 10 sessions. This isn't going to one session and saying, oh, that's what it is. But it's really being part of the group for 10 sessions. And I said to her, you know what, you've got lots to learn. You've got to learn all that surgery stuff and all that high risk stuff that we really need you to be good at. And she said, oh, yes, I know. And that does take time. But she said, you know what, we'll learn that. But there's no guarantee that we will learn what we learn by sitting in a group of women and listening to them talk. And we need to know that too. And so I think it's extremely important. We're looking at interprofessional work. I mean, there may be some more pieces that I work on along with this, but I'm interested in anybody else who has ideas, and CHIs, I think, as well. Interested in how to bring this into more residency and into medical schools and nursing schools. We have medical students who have been involved. In fact, there's a group of medical students at Virginia Commonwealth University that did a project that they then presented at the District ACOG meeting. So that was very exciting for them. But we know that medical students are now looking for residencies that will allow them to have involvement with centering.
Great. Jaden Cohn asks, what do you make of the Carter 2016 meta-analysis that suggested no difference in preterm birth between CP and individual prenatal care? Any thoughts on weaknesses in the paper, or do we just need more data to show that CP is effective when all research is considered?
Right, that's the one that came out from St. Louis. Is that, I think is the one you're referring to probably. And we do have a couple letters to the editor that were published in the January issue of the Green Journal. Because we looked at that and they got back. They also responded very nicely to that. I think, there are, one of the things that is very important with research is that we use similar or the same tools. And when you don't use the same tools, then it's very difficult to have aggregate data. So we are spending more time on at least, I think I'm not as involved at CHI as I was, but I'm still very involved in the research around the country, looking at what are the best tools to use for a particular to look at, if you're going to look at depression, can everybody use the same tool maybe, for example. So I think that's an issue. Another issue is that many of the studies were done on sites that were not approved. So if you look at, for example, the New York data that came from sites that were just getting started and that really had very little oversight on model fidelity. So research that is going to be the most helpful is going to come from sites that are approved, that have the model in effect, and then we know we're really studying that. So we're really, the more things that come out, the better, as long as they come out well-constructed studies. And this is a very, very good team in St. Louis, and we certainly all paid attention to that.
Great. Chanel Comfort asks, do you feel that those that were in the group didn't care about having an ultrasound as much as those who had traditional care because they're able to identify with other women within their same gestational age range, which may decrease their anxiety about the health of their babies, as well as having a structured presentation of what to expect during their pregnancy.
Well, we don't know exactly why that came out, but I think that's probably true. That I mean, women like to have ultrasounds. My daughter is now pregnant with twins, and so you know we just got a 27-week picture of the baby's face and of one of the baby's faces, and we're going, oh wow, look at this. I mean, so ultrasounds, they do something, but I think when it comes, so this is my thinking. We don't really know, why the data came out that way. We just have hunches, and my hunch is that when you're in a group, yeah, the ultrasound is important. And remember, this is somewhat old data when there weren't many ultrasounds done anyway, thank goodness. But there are other things that become more important to the women, and that I put a lot of that in the category of it's an opportunity for women to test out their basic assumptions and their beliefs and some of their cultural values with each other and see if it all fits. And that is such a rare opportunity, because we have very little opportunity really we hear a lot of things and we were told a lot of things, but to really test them out, how does this fit? Does it fit with you? I think those things become more important in the group. And so an ultrasound is kind of it's a one-time thing. You see your baby and that's exciting and all, but really pregnancy is a slug. And all the things that happen during pregnancy, you're trying to figure out what's going on with your body and are you normal? Is it normal or isn't it normal? Those are really the big issues.
Great, I agree. Getting down to the last few here, another group, Alison Bowers just started a group, and all 4 physicians and 3 CNMs have signed up to facilitate. She wants to know, what do you consider to be the best asset for success and the biggest challenge for success?
The asset for success for whom? I think having everybody involved is huge. So having the physicians involved and all of the midwives involved, that's very, very exciting. And hopefully you're presenting it as it's as a standard of care. This is how we do care here. So that when you're going about enrollment, it's like you just assume that women are going to come into group, and there will always be some for whom it won't work, but that should be a very small percentage. And so your message should be, this is how we do care here. And many sites have been successful in having the person who's going to be starting group this month, the clinician, does most of the new OB visits, and then is able to say, I'm starting a group, you're the right, you have the right delivery date for my group, and I think it would be really fun to have you in my group. And so then the enrollment becomes much easier, I think. So that's just one way of doing it. But I think another thing is to have regular times when you can share, and you can share what worked and what didn't work, and who's got an idea for this. And this was a really tough problem that I had to deal with, and I need to talk about it. And so that you gain skills together as you are talking together, and it becomes a real support community that way as well. So you have your own continuing ed going on, and then you make sure that you do one of the advanced workshops after you've had some experience with the group leadership, because that'll give you more ideas as well. And then there, if it's possible that some in your group will be better facilitators than others, and we know that we think we have the data that supports our assumption that it's facilitation that's really the key to success, and that groups that don't go very well, it probably is due to perhaps not that great facilitation by the clinician and the co-facilitator. And so kind of looking at that and looking at, so how do you get better at that, is another possibility. But I think you're on the road to success. It's great.
Okay, Sharon, we're down to the last 2. How have you found that electronic healthcare records have changed the dynamic of centering pregnancy model?
It's made it a little harder for women to directly enter data in their chart, but having sort of a shadow chart or that you might have that has the lab work and that has the ultrasound so women can still see that data, and having them keep up their own personal progress notes. There are ways to get around that, and I think so the important thing is that women have access to their data and that they understand what their lab work means and what the ultrasound report means. That there's an opportunity to really discuss that. And so, and some places have been able to have iPads, and women have been able to enter their data directly into their chart. So if you have that opportunity to do that, that's kind of a nice way to keep them involved.
Great. And then the last question, how do you reverse a patient mindset that group prenatal care is inferior to individual prenatal care?
Well, so you have to sort of think about where did that come from. There are people who think that, oh, I mean, put in a group because it's sort of like group herding, and so that's one place where your patients can be extremely helpful and the messaging. And I know one site that was putting up pictures of mothers and babies, or maybe maybe the partner was in it as well, or had some group pictures, or babies in the baby circle. I think the evaluation slide had babies in a circle there, and with women saying, I want my baby to be in one of those pictures. How do I get to be in one of those? And so I think word of mouth really important. Wearing buttons, having things around that are really positive, having your front desk person is, in my mind, is one of the most important people in your site. And that person says, oh, this is just great. We're so excited about having groups, and you just got to be in one and give it a try. If you don't like it, you can always leave. But it's that kind of positive, come along. We think you're really going to like it. That's going to work. And what our data shows, and again, this is quality improvement, but what our data shows is that our outcomes are better. We have fewer preterm births, and we have breastfeeding is better, and whatever else. And we want you to have the very best experience possible. So it helps maybe the woman to kind of rethink that. But remember that what she knows, she may not like it that much, but what she knows is individual care. And so it's a leap of faith in some ways for a woman to say, okay, I'm going to do this group thing.
Well, and again, as we talked a little bit about that, the new model that you have out there, not new, but the additional model of the group intake can change that as well.
Exactly.
Does anybody have any other questions? Well, Sharon, thank you so much for coming. We've had at least 50 people here, as well as the whole gang at Hayden. So it's really been a super well-received presentation, and we thank you so much. Thank you, everyone, for participating in today's presentation on centering pregnancy and centering parenting and just centering in general. And we hope to see you again for another virtual event hosted by the FNU chapter of the IHI Open School for Healthcare Professions. Save the date, Tuesday, April 25th at 8 p.m. Eastern Standard Time. Sharon, I will make sure you get a copy of this, and thank you so much. I'm going to stop recording.